Thank you so much, Dr. Montgomery and Dr. Nepple. We did have a couple of questions come in during the course of the program. I'm going to go ahead and ask them to you. Feel free to answer as you see fit. So the first question is, how frequently is a bimanual palpitation done as part of the TURBT procedure?
So I'll go ahead and answer that. This is Jeff Montgomery. So, you know, the bimanual exam it should be done on each initial resection. It's easy to do. So if you're having repeat resections or a recurrence, it's easy enough to do a bimanual exam. Now, say you have non-muscle invasive bladder cancer, you have another small tumor that that you develop, you go to the operating room for a resection. It's unlikely that a bimanual exam is essential in that situation. What we want to know is, you know, is there a bulky tumor that is deforming the wall of the bladder that we're able to palpate? Another thing is for men who are having this procedure, it's rarer and rarer that primary care doctors do prostate exams, so the digital prostate exam. So that's another benefit to doing a bimanual exam, in particularly in men, is that you also do a thorough prostate exam. So as far as the frequency is concerned, there's no hard standard on that. But in my practice on all first resections, I do it and document it, but it may not be required for future resections, depending on the situation.
Thank you so much.
Yeah, and from my perspective, I agree with all the points that Dr. Montgomery brought up, and I would just maybe also highlight with initial diagnosis, CT scan gives us a pretty good idea about what a bladder tumor looks like, and some concept about aggressiveness. There may be still be value in doing that exam, but we're not oftentimes finding a small tumor on the scope. CT scan looks okay, and then finding something surprising on bimanual exam. They typically correlate together. I think the other important thing to note from the patient standpoint is we don't separately consent patients for a bimanual exam. Most of us will document it in our operative note, but maybe not universally. So I wouldn't take home that if your urologist has never mentioned a bimanual exam, that something about your care has been lacking. It's actually probably relatively frequent that exam has been done, but it's just not something that in the course of a normal clinic conversation that I typically go into in any great detail. It's more for me a learning point with our residents as we're training them to point out, that, hey, you should do this so you know what normal feels like if you ever do have a bigger, bulkier bladder tumor that you're trying to figure out if it's mobile or not. And the other practical side is if you're a man and you need to have a rectal exam, that, while someone's asleep under anesthesia, that seems like a great time to have it done for everybody involved to avoid that, discomfort that might come with that exam in the course of a clinic visit.
Great, thank you so much. We have time for just 2 more questions. Our next question is, under what circumstances is TURBT done under local anesthesia during an outpatient cystoscopy?
So, TURBT technically implies that it's done with a larger scope that allows the resecting loop that I showed in order to get a deeper sample of tissue. So that is not a procedure that would be tolerated in an office procedure. Now, situations where you have a small tumor that can be biopsied in the clinic, or even fulgurated or burned in the clinic, we do that. It's not all that frequent, but if we do run into those situations, that's something that we're able to perform at that time in clinic. But a classic TURBT could not be done under local anesthetic. It's generally a general anesthetic, or we can do them under spinal anesthetic.
Thank you so much. To build on that, there was another question that was related to that. If they had a tumor fulgurated or burned off in the office and it couldn't be sent to pathology, is there a reason for concern for that?
Yeah, I can feel that one. I think most commonly there wouldn't be a reason for concern if it was something that was quite small and specifically in patients where there's a history of low grade, type of bladder cancer. I think that I've actually seen, research level data that type of procedure is probably way more frequent than is kind of perceived at the academic institutions. I think I specifically in my practice am quite conservative about not doing too many of those procedures in the office, because every once in a while, if you actually remove the tumor and you do the biopsy, you find out that there's a high grade cell there that's not, the low grade type. And that's something that is specifically triggering us to consider different management of liquid into the bladder in those types of patients. And so, I think in general that it's probably a safe procedure if something was small enough that the urologist felt that that was a reasonable thing to do. But if it's something that is happening, if a patient's having a fulguration every 3 months, then there may be situations where it's better to try to go to the operating room and clean out everything, fulgurate everything, and then look at what the pathology is and what the options are. So I'm always very cautious about judging someone's specific example or experience. There probably was good reasoning behind it, but I think it is just good to have an overall concept of it's a relatively uncommon procedure in general for bladder cancer.
And I'll just quickly add that there are situations where people get more frequent recurrences where every time you've sent the tumor that you've biopsied in clinic, it comes back as a low-grade TA, so non-invasive. You look in, it looks like the same exact tumor. There's really no benefit to sending that tumor for a pathologic analysis, and just really adds to kind of the cost of bladder cancer management. So there are circumstances where you would remove the tumor or fulgurate it without sending it to pathology.
Yeah, I agree. That's a great point.
Great, thank you. Thank you so much, Dr. Montgomery and Dr. Nepple, for joining us this evening. That's all the time we have for questions today.